All right, so today we are going to go through immunodeficiency. So we're going to go through T cell, B cell immunodeficiency. We're going to go through causes, pathophysiology, and manifestations. We're going to start off with a T cell immunodeficiency. You guys probably remember from medical school, there's two major types of C cells, right? There's CD8 T cells, and there is going to be our CD4 T cells as well. So they definitely have a little bit of different functions. So if we're going through that CD8 T cell, what is the function of this? Well, you have antigen presenting cells, and antigen presenting cells are going to present antigens to your CD8 T cells. And what kind of antigens do they present? Well, usually they present, in this case, intracellular antigens, so things like viruses that can live intracellularly, and also, antigens from neoplastic cells, so any genetic abnormality that creates antigens that look like they're neoplasm. These are presented to your CD8 T cells, and your CD8 T cells subsequently respond with things like perforin and granzyme, which then subsequently kills that antigen presenting cell that's either infected with a virus or is at increased risk for neoplasm. This is kind of it scans for viral infections as well as scans for malignancy, and subsequently kills malignancy before it starts in the body. So for CD4 T cells, we're mostly going to go over Th1 CD4 T cells here, but what do these do? So a little bit different than what CD8 T cells do. CD4 T cells really scan the body for atypical antigens. Antigens we'll go into a little bit, but like TB, fungal antigens really that aren't recognized by antibodies, that aren't recognized by the humoral immune system. What this Th1, CD4 T cells do in response to that, instead of being able to kill them, they activate macrophages and they basically wall off these atypical intracellular antigens so they don't infect the rest of the body. So that kind of gets into some of the infections that you are at risk for with a T cell immunodeficiency. So you have a decrease in your CD8 T cells, so you increase risk for viral infection. The ones that you'll see a lot, especially is going to be herpes viridae viruses, which interculate into your DNA, which really rely on CD8 T cell cytotoxicity to get rid of. You may see things like CMV, EBV. These patients will be at high risk for. Certain atypical bacterial infections you may think about. So T cell immunodeficiency gets you a risk for listeria, progression of syphilis. Especially patients with HIV/AIDS can go right from primary syphilis to neurosyphilis. This is always a concern. Some of your zoonotic infections, which have a granulomatous response to them. And then lastly, fungal. Things like PJP, pneumocystis pneumonia, cryptococcus, as well as protozoa. So things like toxo. So what are some of the causes of T cell immunodeficiency? There definitely is some genetic abnormalities that cause this, and patients, you may not be recognized that they have genetic abnormalities for fungal infection until seemingly normal patients, normal immune systems can get these can get systemic fungal infections, and may have some genetic variation in genes that code for cytokines like IL-2, cytokines like IL-12, interferon gamma as well. That puts these patients at risk. But a lot of times T cell immunodeficiency is going to be secondary to something else. Commonly we see is going to be HIV/AIDS, which causes a CD4 T cell immunodeficiency by actually HIV direct killing of the CD4 T cells. But you get risk of loss of CD8 mediated cytotoxicity and subsequent viruses like CMV, as well as increased malignancy, especially EBV-associated malignancy being an oncogenic virus with patients with this. And it's actually because that CD8 T cells are very involved with this. The CD4 T cells actually activate the CD8 T cells, and they work together and function together, with loss of CD4 T cells secondary to HIV/AIDS, putting you at risk for loss of function of CD8 T cells and subsequent viral infections as well as cancer. All right, so what other things may you see? Transplant, especially being on IL-2 inhibitors. Transplant being on things like IL-2 inhibitors may put you at risk for T-cell immunodeficiency, and then steroids, glucocorticoids as well put you at risk for B-cell immunodeficiency as well as T-cell immunodeficiency. All right, so let's go to B cells. So what are the B cells important for? So B cells important for really recognizing those, I'm just going to say, pretty normal, typical bacterial antigens, right? So they scan the body, they look for bacteria, very much encapsulated bacteria as well. And then what you get in this setting is B cells that can bind IgM from that bacteria and secrete IgM, or they can function with T cells, secrete IgG to subsequently kill that bacteria as well. So you have that kind of antigen on that bacteria. It's subsequently presented to B cells, and in response, B cells create immunoglobulins, which subsequently kill mostly just normal, typical bacteria. So what kind of things do you get at risk for with B cell immunodeficiency? It's going to be bacteria. That's your biggest one. IgM that's made in the spleen, can really bind bacterial antigens. It's on the B cell and subsequently increase your IgM response, which then kills that bacteria, or the B cells can then subsequently bind with T cells and create IgG for that long-term lasting immunity. So bacteria, staph, you're at risk for, and then really any of your encapsulated organisms as well. Things like H flu, things like strep pneumo, these patients are high risk for. With IgA, and remember IgA is more present on mucous membranes, you think about a lot of sinopulmonary infections, so things like strep pneumo, H flu again, as well as GI infections, so things like norovirus, Giardia, and even a lot of times your bacteria that cause dysentery you'll be at higher risk for. So what are the causes of B-cell immunodeficiency? So primary causes is the biggest one that you see in adults is common variable immunodeficiency, the abnormality of T-cell receptors binding with B cells and subsequently causing a more robust antibody response. Loss of that interaction with B and T cells and T cell priming of B cells to create IgG puts these patients at risk for subsequent bacterial infections as well as sinopulmonary and GI infections, CVID, and then specifically with that IgA deficiency, if you have that by itself, you just have risk for those mucosal infections. Secondary, you will see a good amount of cause of this. One of the things that you get tested on the most is it relates back to the pathophysiology. B cells that have that CD20 receptor on their surface and CD20 receptor antagonists or antibodies, things like rituximab, will put you at risk for infection secondary to humoral immunodeficiency. You may see also other reasons that patients can lose immunoglobulin, like cirrhosis, with the creation of decreased creation of immunoglobulin, as well as asplenia, which really puts these patients at risk for encapsulated bacterial infections. And lastly, with loss of immunoglobulins to the urine, nephrotic syndrome. All right, the last one we'll talk about is going to be for complement deficiency. So let's talk about complement a little bit. Complement, there's a couple different pathways. Mannose binding pathway, there's antibody-mediated complement attack. We'll talk just about antibody-mediated complement attack of subsequent bacterial infections. All right, so bacterial infections bind, that's not a very good immunoglobulin. Immunoglobulins bind bacterial infections, and then subsequent recruitment of things like neutrophils, to that area of infection is done by our early complement, CD1 to C4. And then your late complement is going to be C5 to C9. Is very important for the membrane attack complex, which goes and perforates that bacteria and subsequently kills that bacteria. So you'll see some abnormalities, and there's a difference between early complement and late complement of what infections they put you at risk for. So early complement is basically similar to B-cell immunodeficiency. You get risk of encapsulated bacteria as well as staph. The other things that you may see with this is actually increased risk for lupus. And the reason why is your early complement is really important in clearance of intranuclear antigens. So say you go out in the sun, you get apoptosis of your keratinocytes, and then after apoptosis, there's a lot of nuclear antigens kind of just hanging around. Your complement is responsible for clearing that, and if you do not clear that quickly, you may develop an immune reaction to it. You may develop anti-nuclear antibodies, which is the hallmark of lupus. You may subsequently develop lupus. So early complement deficiency is actually a huge risk factor and can cause lupus in and of itself. And with that early complement deficiency, you'll actually have risk for your encapsulated organisms as well as staph. Late complement is a little bit different, and with late complement, there is a much higher risk for Neisseria infection. So these patients may get Neisseria meningitidis. These patients may get disseminated gonorrhea from secondary Neisseria. So the thought is that the lipopolysaccharide on the membrane of Neisseria is very, very susceptible to complement, and our body really relies on late complement with that membrane attack complex to kill it. So late complement really puts you at risk for Neisseria. And lastly, there is some of acquired causes. We went through the primary causes, which make it early complement deficiency, secondary to genetic abnormalities, late complement deficiency, secondary to genetic abnormalities. But there is also a late complement inhibitor used in PNH. So a secondary cause of complement decreased complement is going to be that antibody called eculizumab, which is CD5 inhibitor used in PNH, and these patients actually do get risk for Neisseria infections, including Neisseria gonorrhea and Neisseria meningitidis. All right, so that's basically all I got. Thank you all for watching.